Yeah, I think it's 1 o'clock. We've got the people. Rahat is also here. Yes, good. So, Assalamu alaikum viewers. My name is Dr. Kashif Chauhan. I am the pediatric surgeon working in UK. Today's topic, as you all know, is extremely important topic involving the diabetes and its effect on the COVID-19. And I think it's one of the burning topics, especially back in home, whether you're living in any country of the Asia or any country of the Europe. We have got three of our elite speakers who very kindly taken their time out from their busy schedule to give a talk on this one. Now, this one is going live on Facebook and also on the federal government of Pakistan program Yaran Watan, which we are very grateful for that. This teaching program is in conjunction with or in collaboration with the NODFA, which is National Overseas Doctors Family in UK, and also with APPS Europe, which is Association of Pediatric Physicians and Surgeons of Europe. Let me introduce you to the panel first, and then I will give the mic to the panelist. First of all, with great prayer, I'd like to introduce Dr. Jawad Bashir, who's a consultant endocrinologist and has kindly taken his time out, especially on Saturday, to give us a talk on this very important and relevant topic. Then I've got Dr. Rahat Ali, who's also a consultant endocrinologist, who very kindly again taken his time out to give a talk on this very important topic. And then I've got Dr. Habib Haider, who is a consultant in acute and stroke medicine, who will talk about the diabetes and stroke and its related problems, because diabetes and strokes, sometimes they are very interrelated. And Dr. Habib was quite busy today. I think so. He just finished his shift. And thank you very much, Dr. Habib, for all this. So I will now request our honorable guest speaker, Dr. Javed Bashir. Can you please take the mic and start the session? Thank you.
Thank you very much, Kashif, for the generous introduction that you've given. I would just start by sharing my screen, and if you could just kindly confirm that you can see the screen. Is that okay? Is that visible?
Yeah, we can see your screen.
Yeah, I'll just hide the thumbnails. So I'm Dr. Jawad Bashir. I'm a consultant endocrinologist at Basildon University Hospital in the UK, and I have the honor to speak on this topic, which is diabetes in relation to COVID. This is a hot topic. As you know, we have been in this pandemic for about a year, and the discussion points that I want to raise from this meeting is number one, the effect of diabetes on COVID, and number two, the effect of COVID on diabetes. They are both interrelated to each other. As we all know, where did it all start? A year back, more than a year back, in a tiny province of China, Hubei, a place called Wuhan was the one where the first few cases of COVID were reported. And from there onward, it spread like a pandemic throughout the world. And we were in a state of denial for at least a few months before we realized that this is a genuine pandemic and it does exist. And before anyone could take measures to actually stop the spread of this lethal disease, it spread across the world in a matter of few months. And it takes me back about 1400 years back when our Holy Prophet Muhammad Sallallahu Alaihi Wasallam gave a fantastic advice, which really kind of hits my heart, that if you hear an outbreak of a plague in a land, do not enter it. And if the plague breaks out in a place while you are in it, do not leave that place. Such an amazing advice. This is from Sahih Bukhari. It's a genuine hadith, and it's just an amazing advice about pandemics. 1400 years back when we had no idea about science and medicine. Now, because China was the first place where it all broke out, it makes sense that they would understand this condition more than anyone else because they have seen it more than anyone, and they have had the longest duration of this condition. Hence, I'll start with a study quoted by one of the Chinese scientists panel about the influence of diabetes on severity and fatality of COVID-19 infection. This is a recent article published in a reputed journal of diabetes, obesity, and metabolism with quite a high impact factor. And they did a meta-analysis on all the cases that were admitted in hospital with COVID and diabetes. And one of the interesting findings was that they they almost unanimously showed that if you have diabetes and COVID, you have got 3 times more chances of dying. The fatality of COVID-19 infection was threefold if someone is suffering with diabetes. Now, what does this tell us? If you have COVID and diabetes, this is a lethal combination. Now, this is a lesson coming from observational data after about 12 to 18 months, looking at cases from observational studies. And this is what happens in pandemics. When you have a pandemic, majority of data comes from observational studies because we cannot run lengthy randomized controlled trials. So let's have a look whether the same results are recapitulated in the UK. And there's a recent study about mortality with COVID in England from March 2020 to May 2020, the first 2 months. And that's been done by a very reputed group of endocrinologists. And some of you who actually work in the UK as endocrinologists, you know certain names like Professor Parthaker. And I really appreciate these people working very hard, just like all the doctors across the globe. But they've gone an extra mile to gather all the evidence and actually help us understand this lethal condition. What they did was they looked at all the admissions with COVID-19 in those first 2 months when the first wave of COVID-19 hit the UK. And they looked at the mortality rate per 100,000 persons. And one of the observations was that among the 23,000 deaths, 33% of people had diabetes. And this was a remarkable observation because 1/3 of the people who died with COVID actually had diabetes. Hence, they did another deep dive. The same team actually looked at it in more detail, that what was the impact of diabetes on COVID-19 mortality. Now, if you look at the age breakdown, now the first two graphs at the bottom, as you may be able to see, so these are the people who have no diabetes and then the overall population. If they grow older, the mortality, the deaths per 100,000 people is about 400 deaths per 100,000 people. But when they looked at the people who had diabetes, so this is the COVID mortality that we're looking at. So both type 1 and type 2 diabetes was associated with much higher mortality rate. Now, the figures for type 2 diabetes are much more significant because we have got a bigger number, about 7,400 deaths. But that for type 1 was with fewer numbers. But again, the odds ratio are suggesting that you have 2 to 3 times higher chances of dying if you have diabetes and you get infected with COVID. Now, this generated a lot of other observational studies as well. And the same team actually did another deep dive looking at the correlation with the severity of diabetes and the control of glycemic control. So what they started to do, they started to look at the weekly registration of deaths. So this is from 5th of January. The pandemic started in UK around the 13th week of 2020. So around about by 20th of March, we had the first wave of pandemic hitting us hard. So if we look at the total deaths in 2020, they were not different from the mean deaths in the last 3 years. So the weekly death rate was more or less the same. So those people who actually don't believe that a pandemic exists, these figures are fairly remarkable findings, because the death rate was not different until the pandemic hit. And just as the first few cases were reported, there was an outburst of deaths. And this outburst, again, they kind of broke it down. So this is only diabetes, people remember. So type 1 diabetes we're talking about. And if type 1 diabetes people's mortality rate was seen overall, if they didn't die with COVID, it remained more or less the same. But if they did have COVID, the mortality shot up quite high. And the figures were far worse if you look at type 2. So the same thing for type 2, overall mortality. And as soon as the pandemic hit, and you can see this is exponential rise, because for type 1, the figures here were in 300s, but now it is 6,000 deaths. And this is massive. So clearly, diabetes and COVID is a lethal combination. And this was something which was fairly new to us, because we know people who have diabetes, they have got risk of dying due to other complications with diabetes. But why would COVID cause them to die uh, more frequently was something not understood. So another deep dive was done. And this was again looking at all the deaths with type 1 and type 2 due to COVID, and all other deaths of type 1 and type 2 diabetes. And it was interesting that both type 1 and type 2 diabetes people, if their HbA1c is higher than 75 millimoles per mole, which is 11% in the old money, they're more likely to die, whether they have type 1 or type 2. So this is an independent risk factor for mortality with COVID-19. If the glycemic control is poor and you have diabetes and you are old, you're more likely to die with this condition. Now, further studies came to understand why do these people have worse outcomes? And as I said in the beginning, that these pandemics, they are a steep learning curve for us. We cannot generate conclusions immediately from day one, because we don't know what's happening. I hope we all survive this pandemic, and this is probably the last one in our lives. But these pandemics generate evidence as the time goes by. So this study looked at the pathophysiology of COVID-19. So COVID-19, which is severe acute respiratory distress syndrome, happens as a result of coronavirus. It leads to damage to the beta cell. That's one of the possibilities. Whether it is due to thromboembolic state, or is it due to beta cell damage due to direct toxic effect of the virus, we don't know exactly. And we all know that they have a cytokine storm, which leads to the sudden deterioration and requirement of level 3 care. And that leads to a lot of other metabolic effects. So even at the time of admission, they may have hyperglycemia. If they have diabetes, they may have worsening metabolic control. They could get HHS. They could get diabetic ketoacidosis. And again, due to the insulin resistant plus insulin deplete state, we have seen a lot of new onset cases of diabetes, whether it's type 1 or type 2. And and you know, if someone has diabetes, particularly type 2, they are having other problems like obesity, they have got inflammation going on, they have coagulopathy, they may have other complications of diabetes, the acute complications like DKA or hyperosmolar hyperglycemic state. They're generally older people, which isn't great. They may have cardiovascular risks or even renal disease, which doesn't help. So all these factors, along with COVID and a state of insulin deficiency and insulin resistance, leads to poor outcomes. And that kind of makes sense that these people do worse than general public. And there are a lot of hypotheses and theories around endothelial cell damage that diabetes causes. They can get strokes and kidney problem thrombosis. But one of the interesting observations is that we have seen more new diagnoses of type 1 diabetes in children during the COVID pandemic. And this is a small study from one of the Northwestern London hospital units that they notice that there were 30 new cases of type 1 diabetes reported during the period of COVID pandemic. This is an 80% increase in the incidence for that particular time period. And 70% of them presented with diabetic ketoacidosis. This generates a hypothesis that these people who have COVID 19 infection, number one, they either become insulin resistant or they have an insulin deplete state, which leads to diabetic ketoacidosis and the diagnosis of type 1. Now, while we understood more about the COVID 19, the recovery trial was one of the few trials in the UK that showed some promising results with the use of dexamethasone, and it is being remarkably being used for treatment of COVID 19 among people who are either requiring oxygen or they are requiring invasive ventilation. And this Kaplan-Meier curve shows that the red graph is the mortality. So the mortality with use of dexamethasone is less if people are requiring oxygen. And same applies to the mortality with dexamethasone if they are on invasive ventilation. And the protocol here currently is to give 6 milligrams of oral dexamethasone for 7 to 10 days to all patients who are requiring oxygen as a result of COVID 19 infection. This doesn't help diabetes, as we know that dexamethasone is going to worsen the glycemic control, and hence our role as endocrinologists becomes even more important to help people achieve euglycemia. So, in summary, we know that one third of COVID 19 related deaths in the first wave were in people with diabetes. We also know that if people have diabetes and they get COVID, there is 2 to 3 times more chance that they would die as compared to a person who doesn't have diabetes. The worse the glycemic control, i.e., that the hemoglobin A1C is more than 11% or 75 millimoles per mole, the worse is going to be the outcome. COVID 19 induces a unique pathophysiological change, whether it is insulin resistance or insulin deficiency, we don't know, or it could be combination of both. Hence, we are seeing more cases with diabetic ketoacidosis, more cases with hyperglycemic hyperosmolar state, and more cases with new diagnosis of diabetes. And obviously, with the use of glucocorticoid, we will have further challenges because the glucose control is going to get worse. This is a challenge. The advice is to stay at home, stay safe, maintain the advice that our Prophet Muhammad ﷺ gave us 1400 years ago, not to go to a place where there is a pandemic, and do not do mixing of people. Thank you very much.
That's really nice of you, Dr. Jawad Bashir. That's a very nice insight of the things which you have explained, which is really nice of you. In fact, I've learned a lot by listening to your talk. I have gotten my knowledge regarding diabetes and COVID related was not, as good as yours ones are, obviously. But even as a doctor, your presentation has, increased my knowledge, so that whenever I go and talk to my relatives or my friends or my patients, I can always tell them, especially your last slide regarding your summary, and especially the mentioning of, our prophet, Hazrat Muhammad Sallallahu Alaihi Wasallam, that the things which they have explained us 1400 years ago are all, coming into life. So we should, understand that point of view also. But thank you very much for your talk. That's an excellent talk. So now let me introduce you to Dr. Rahat Ali Thani, who is a consultant endocrinologist also. So Dr. Rahat, please, the mic is yours for your talk. Thank you.
Thank you very much, Dr. Kashif. I will be talking about the practical aspects of the management of diabetes. So first of all, some housekeeping stuff. This presentation is mostly about the working in the UK, but I will be trying to translate it to Pakistani and other and obviously other healthcare settings. In addition to the units of millimole per liters for glucose, you could multiply that with 18 to get a reading in milligram per deciliter, which is used in Pakistan and in the US. So let me share my presentation first, if that's okay. So is everybody able to see my presentation at all?
No, Dr. Rahid, I think so. You have to just press that share button, again.
Again, okay. Let me see that.
Yeah, there is something. Yeah, exactly. If you can just increase it. Yeah, we can all see your presentation now. Yeah.
Perfect, perfect. Okay, so so let's start with some cases and see what your learning needs are and see where we can optimize those learning needs. So I'm going to talk about typical cases that you would see in a hospital setting. There's a 67-year-old man who's got type 2 diabetes for more than a decade. He's treated with standard full dose of metformin with a bit of sulfonylurea and a DPP-4 inhibitor. He's overweight with a BMI of 32, and he doesn't check his blood sugars regularly, but his HbA1c was high, 8.4% DCCT, 68 millimoles per mole UKPDS 4 months ago. So he's admitted with COVID-19 pneumonitis, and he's clinically hypoxic and tachypnic. You see chest X-ray is showing bilateral infiltrates suggestive of COVID-19 pneumonitis. You commence him on IV dexamethasone 6.6 milligrams and high flow of oxygen. Optiflow is a method of administering high flow oxygen in patients with COVID. It can administer up to even 100 liters of oxygen per minute. His blood sugar is high, is 21, which is about 370 in milligram per deciliter. And there's no problem with the acid-base balance, although you could argue bicarbonate is in the lower end of normal. So how would you manage this man's hyperglycemia? Anybody wants to comment, or shall I go forward with my further cases and we can discuss it later? Does anybody want to comment? I'm open to looking at the chat box.
Or I'll tell you, for this session, if Dr. Rahat is doing that thing, if anyone wants to unmute himself or herself and wants to, answer, that will be nice. Otherwise, Dr.
I can
Rahat,
carry on otherwise. That's fine. That's fine. I have not had any anything in the chat box yet. So let me just check once again. Okay, somebody has commented upon VRII. That's not a bad suggestion. Very good, very good, very good. So we'll talk about that in a minute. And then you see another man who's very similar. He's got less duration of diabetes, less medications, probably not that obese. And then we've got uncontrolled diabetes on the HbA1c, probably not that much as compared to the man before. He's admitted with COVID pneumonitis, and he's on small amount of oxygen along with oral dexamethasone, which is 6 milligrams oral. His random blood glucose is high, 17 is around 310. So again, we'll talk about how we'll manage this person's hyperglycemia. And then another young lady who is fit and well, not known to have diabetes, admitted with cough, fever, and vomiting, not eating and drinking. Clinically, she's dehydrated and her COVID swab is positive. She's not hypoxic and is not requiring any oxygen and hence no steroids. Her glucose is 10.1. So this is a lady who's not known to have diabetes. Her blood sugar is about 200 milligram per deciliter. So how will you manage? Does anybody know what the diagnosis might be for this lady? Does anybody want to mention in the chat box? Okay,
I think that,
I think we
if
should.
anybody wants
I'll
to
probably
write
carry on and explain
anything,
that a bit later.
if anybody wants to write anything, because this is an educational session for all of us, including myself, despite of the fact, I've got a limited knowledge in medicine, but this is a very nice, session. So if anybody wants to write anything, please use the chat box, and Dr. Rahat Ali will be able to answer, all your questions.
Okay, so if you want to interrupt me during the presentation, I'm happy to take any questions. That is absolutely fine. So then another lady who's old, she has insulin dependent diabetes for the last 34 years. We don't know if it is type 1 or type 2. She takes quite a fair amount of insulin in the night every day with no other insulin or oral hypoglycemics. She's had no HbA1c. She does not monitor her sugars. She's admitted with acute confusional state and was found to be COVID swab positive. She's also got suspected UTI and is on antibiotics. She's not requiring oxygen and she is not on steroids. Her blood sugar is 3.2, which is about 58 milligram per deciliter in Pakistani units. So we'll talk about how we will manage this person. So let's go to the practical considerations of how you will manage a person who has diabetes and is admitted to the hospital with COVID-19 infection. So these are some of the slides are a bit busy, but I'll explain while I'm talking. So consider a typical presentation always. So diabetes in COVID can present in any way. It can present with DK, it can present with starvation ketoacidosis, it can present with euglycemic acidosis, it can present with HHS, which is hyperosmolar hyperglycemic state, where there are typically no ketones, but the osmolality becomes very high because of extremely high glucose levels. And it can also present with a combination of two. It is also good to know that, as Jawad has mentioned, that COVID-19 can also contribute, if not cause, new diagnosis of diabetes because of the insulin resistance caused by COVID-19, because of the a destructive effect on beta cells. So the insulin secretion is also compromised, along with the effect of steroids, as well as the disease stress itself. So how you diagnose DK, I will not go into that. You probably know. You should have high glucose or have known diabetes, high ketones of more than 3, or urine ketones of more than 2. Metabolic acidosis, that is DK, and HHS is where you have extremely high glucose, dehydration, and osmolality of 320. For those of you who don't know how to calculate osmolality, you can multiply sodium by 2, potassium by 2, and glucose without multiplying anything. So 2 into sodium, 2 into potassium, and plus glucose. So that will give you your plasma osmolality. The normal serum osmolality is up to 295. So if it goes above 320, we say it is usually indicative of hyperosmolar state. So the take-home message is you should be checking glucose in all patients, whether they have diabetes or if they do not have diabetes. Check glucose on all patients admitted to the hospital with COVID-19. Now, you not only just the finger prick test, which is a capillary blood glucose, but also a venous blood glucose, because if your blood glucose, capillary blood glucose does not check your blood glucose of more than 33. So it will just say 33. So you don't know whether the glucose is actually 50 or 60. And check VBG in all patients admitted with COVID, which means you need to know the acid-base balance before you can institute appropriate treatment. And check ketones in all patients who have diabetes or have metabolic acidosis or have high blood sugars. This is very important. And going back to the case number 3, the lady who had a blood glucose of 10.1, she actually had high glucose, only slightly high, not very high, but she had ketones in her urine. So, which means that she could be having euglycemic decay. You follow your hospital's protocol for DK and HHS, which is IV insulin, IV fluids. You need more insulin in DK and you need more fluids in HHS. Consider stopping some of the medications. Metformin, it can contribute to lactic acidosis. It can contribute to acute kidney injury. It can also lead to diarrhea in acute settings. As we all know, COVID is also associated with colitis and gastroenteritis. So consider stopping metformin. There were some studies initially in about May time last year when they suggested that metformin could actually improve mortality in COVID-19, but that study has not been replicated. So our generous advice is for you to stop metformin. Also recommend, could you please switch off your microphones? Thank you. So we also consider stopping all the SGLT2 medications, which are canagliflozin, empagliflozin, dapagliflozin. These can contribute to dehydration by glycosuria and osmotic diuresis. So you pee more glucose as well as you pee more water through the urine. So that can cause dehydration and ketosis. And you should also consider stopping GLP-1 agonists, which is exenatide, liraglutide, dulaglutide. The reason is that these are the agents that reduce your appetite and increase satiety. So, and in patients who have COVID, they already don't have very good appetite. And actually, some of them have lost quite a lot of weight. So you want to avoid all of that. And then how you want to treat that is with insulin. As Jawad has mentioned about insulin resistance and problem of pancreas not secreting enough insulin, most of the patients require very high amount of insulin. And you should consider seeking a senior endocrinologist, a senior diabetes team input as soon as possible. Kashif, can you please mute?
Yeah, and I'm trying to do it. Habib, you're for the host. Can you just mute everyone? Habib, can you hear me?
Kashif, as an admin, you can unmute. You can mute them. Sorry about the interruption. Coming back, so you would want to stop most of their oral medications and you would want to start them on insulin. Whether you want to give them IV insulin or subcutaneous insulin depends on how unwell they are, and we will talk about that in a minute. So fluids should be individualized. You need to be careful in older patients and patients at risk of cardiovascular disease. And the fluid assessment needs to be dynamic. You need to assess the volume status of the patient every now and then. Hello, Kashif. There is some problem. I think somebody.
कैंसिल मत कर भोसड़ी के फिर आ जाएंगे हम आदत कटुए
Very sorry for the interruption again. Our admin have taken action. So we're talking about fluids and going on to electrolytes. Apart from replacing the insulin, which causes hypokalemia because of the shift of potassium from blood into the cells, these patients are also at very high risk of getting refeeding. So it is imperative that you check all the electrolytes, including magnesium, calcium, phosphate, and check the QT interval on the ECG, because some patients may require ECG monitoring. Depending upon how much capacity there is in your hospital, you may want to take ITU's advice on sorry about the interruption again. Kashif, I think you need to unmute everybody apart from yourself and me.
अबे अनम्यूट नहीं, म्यूट भड़वे।
Kashif, can you hear me?
No, he can't.
Okay, I think somebody may have hacked Kashif's account. So I will hold on for a moment.
To nationalists, we have hacked this meeting.
Hello? I'm not the host. You are Kashif. Okay, thank you. I'm sorry for, I think somebody has hacked our meeting, so the admin is unable to access and control the meeting. So I'll stop sharing,
Yeah.
and we'll rejoin shortly. Thank you.
All right. Sorry about that. Sorry.